So this brings up exporting the agent to earlier stage, particularly to the adjuvant setting. Before I have Mark Chris comment on that, I'd like to hear from everybody else. Mark Szynski?
I don't think we have any data to support the use.
Certainly no phase 3 data yet.
No phase 3 data, which is what I think from a standard of care outside of a clinical trial. I think when you're making recommendations as a standard of care for patients, those recommendations need to be based on phase 3 data where you know there's a benefit. If anything, from the Canadian trial, which looked at adjuvant gefitinib, there was a suggestion that it might not be a good strategy compared to placebo, even though none of us consider that the definitive.
That trial was
experience.
Aborted because of the negative ICEL trial.
There are lots
How
of.
many patients did they report on?
15.
15.
Yeah, there are not a lot. Yeah, but we're drawing conclusions about immunotherapy on 5 out of 6 responders. So I don't.
It
I
certainly
don't
gives us pause.
Yeah, I don't know that. I don't know
You'll
that.
have your turn.
Yeah, I don't know that we have any data to suggest that it's the right thing to do above and beyond adjuvant chemotherapy in that population. Remember, we just established that these patients are more responsive to platinum-based therapy, and that may actually be a very good treatment for an EGFR mutant in the adjuvant, and they may have a better relative benefit from platinum-based chemotherapy than a wild-type population. We don't know that yet.
Heather, your thoughts? Would you empirically give an EGFR TKI in the adjuvant setting?
I would not. But I think it's an important research question and one that's ongoing. So the RADIANT trial, adjuvant erlotinib study, the pre-selection was only for EGFR by immunohistochemistry or FISH.
FISH,
And
yeah.
Both, right, either or. And so we know from earlier presentations that about 17% of the patients on that trial do have EGFR mutations. And so we'll have some data when those results come out about the role.
More than 15.
Huh? More than 15. Some data in a randomized setting about the role of that compound. Is it going to be definitive? Absolutely not. The NCI, of course, is working on a large intergroup study that will look at adjuvant erlotinib in patients who have an EGFR mutation in their tumor. And so that trial is in the works, should be opening hopefully sometime this year, and that will give us definitive data, hopefully. There are, of course, non-randomized, regardless of the end, non-randomized data that have come out of Memorial and also the SELECT trial that do look very encouraging for patients who have EGFR mutations who get an adjuvant erlotinib. But again, that's not randomized, and I think it's very difficult.
After 2 years, when the drug is stopped, you start seeing recurrences.
Right, and you don't
in fact,
know.
a precipitous drop in the PFS curves.
Right, and so one can argue that in two directions. One can say, well, see, we're helping these patients by delaying that, or you could say we're actually bringing that on potentially by some sort of a selection pressure. And so without the randomization, I think it's very, very difficult to draw any conclusions in an adjuvant setting.
It raises the whole issue about how the duration of therapy as well.
Yes, and so with the BR19 data that Mark had alluded to, I mean, even if it was small numbers of patients with EGFR mutations, it was certainly enough to pause. I mean, the hazard ratio was not, it was pretty substantial separation for the patients who were getting gefitinib who had an EGFR mutation. As far as fall off. Now, Mark's making lots of very big eyes here as I say that, and I understand it was a very flawed trial. It was stopped very early. Those patients did not get a full 2 years of gefitinib by and large. You know, it's very, very small numbers, and I certainly would not make any conclusions based on it, but it does make me pause and not think that we are at a point where we should be recommending adjuvant use of targeted drugs.
So before I hand the floor to Mark Chris, Ben, any further comments? Empirically off trial, yes or no?
No, I don't. I think that we have to look back and really, patients with stage 1, 2, 3 resected tumors, even in the best case scenario, their 5-year survival rates aren't great. Stage 2 resected followed by adjuvant chemotherapy, 5-year survival rate anywhere from 35 to 45%. And I think we're eager to improve these outcomes. And the question is, in the absence of data, are we so eager to borrow? Absence of randomized data, are we eager enough to borrow from the stage 4 setting and apply it into the adjuvant setting?
But remember, in stage 4, there's no survival.
That's
advantage.
correct. Right. I think that this question will hopefully be answered by the Alchemist study that Heather just talked about. It's looking at banking over 8,000 resected specimens and attempts to do two things. One is to link EGFR and ALK-mutated tumors to clinical trials, and two is to follow these rare mutations and see how they do prospectively. So I think until we have definitive prospective data, I'm not in the business of routinely prescribing a drug that's costly and potentially toxic.
Rash and diarrhea. Mark, Chris for the contrarian.
You gotta love oncologists. So let's take this. We love negative data. We just love it.
No, we don't.
Oh, yes, we do. We love it. So let's take this scenario, and I want an honest answer from you. Let's say Dr. Chris, in a 1,000-patient randomized trial, in a cohort of 15, showed a significant difference for the therapy. I tried to publish that in the Journal of Clinical Oncology. What would my chances of getting that published?
Depends on who your reviewer is.
A good honest answer. But people are crazed about negative data, and that's sort of the way it is in oncology. Well, let's talk a little bit about data. The first is GIST. How many people did they need? GIST is an FDA-approved drug with 3 years of therapy now in the adjuvant setting. I'm sorry, GIST, I'm sorry. Imatinib is an FDA-approved drug for
In
GIST.
patients with GIST, yeah.
Gastrointestinal stromal tumors, and giving it for 3 years. How many people were in those trials? Hundreds. And they all had mutations. You need hundreds of patients with mutations to show an important, approvable thing. And we don't have that. The data that we have, that we've published, our phase 2 single institution data, says you need about 320 patients to do it. 320. So that's really going to be the answer. And believe me, I've been proposing this for a long time, and those of you that know me, I've been really trying to do this trial, and it's been kind of frustrating that we haven't. The second thing is the Radiant, unfortunately, is only going to have 170 mutation patients. So it's likely not going to do it. I mean, there could be some huge benefit, and that would be wonderful, but the likelihood is it'll be another, quotes, negative trial. But it's not really negative. They didn't have enough patients.
Sufficient power.
Yeah, and even in the who's doing it? The Alliance people doing the randomized trial. I think the number is somewhere between, it's about 300?
350
Yeah,
or so.
300 to 400. So that's what we need. So
Right.
please
Yeah.
So
pay
the
attention to
benefit
the
of everybody, the
numbers.
Alliance trial is looking at only
Yeah.
3 months of induction with erlotinib.
Oh, that's,
No, that's
in
the-
the
I'm sorry,
chemoradiotherapy.
Yeah.
That's the
I'm
stage
talking about
three
the adjuvant trial.
Yeah, adjuvant,
That'll
the
be
other-
part of the Alchemist
Right.
plan.
So, Mark, let me ask you a question. So with regard to the Alliance trial, the adjuvant setting, would you put one of your patients on that trial?
That's a tough one, actually.
That's why I
Yeah,
asked.
I already have a trial open. I don't know. I honestly don't know.
Do you have
I don't. You know me. I don't have much equipoise.
Whereas I think your
Yeah.
other 4 colleagues here do
Yeah,
have
but again, but remember, 10 years ago, when the EGFR mutation was discovered, everybody told us we were crazy, and nobody believed it. Let's be honest. Nobody believed
Well,
it.
I hope you're right.
And it took
but
10 years.
I still have a
10
healthy
years to
degree
make it a standard
skepticism.
of care.
This has been a very lively discussion on a very important topic. Remember, at least 20% of our patients are now identified as having oncogenic drivers, and that has, just in the last 7 to 10 years, completely changed our approach to non-small cell.